Good afternoon, everyone, and welcome to today's special Fireside Chat hosted in collaboration with the Leukemia and Lymphoma Society. I'm Amna Hussein, the Community Outreach and Engagement Manager at the Masonic Cancer Center, and I will be your moderator for today's session. It's a pleasure to be here with you today for this important conversation in honor of Blood Cancer Awareness Month. The Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. The Office of Community Outreach and Engagement serves as a vital bridge between the Cancer Center and communities across the state of Minnesota and beyond. Our dedicated team is committed to reducing the burden of cancer by actively engaging communities and providing access to relevant knowledge on the latest in cancer research, prevention strategies, the importance of screening and early detection, treatment options, survivorship, and opportunities for clinical research. Today, we'll explore the complexities of blood cancers, discuss resources available for patients and their families, and hear a powerful personal journey. Our goal today is to raise awareness, provide education, and offer hope to everyone affected by blood cancers. It is now my pleasure to introduce our distinguished speakers who will guide us through today's conversation. First, we'll be hearing from Taylor Kadlac, who will share a bit more about the Leukemia and Lymphoma Society. Taylor joined the Leukemia and Lymphoma Society in 2024 as the Patient and Community Outreach Manager for Upper Plains region covering Wisconsin, Minnesota, North Dakota, and South Dakota. Taylor earned her BS in microbiology and has spent the last decade connecting her community with opportunities and resources to improve the quality of care and life. Her current focus is on providing information, services, education, and other outreach to patients, caregivers, survivors, and healthcare professionals in the blood cancer community. Next, we'll hear from Dr. Zohar Sachs. Dr. Sachs received her undergraduate degree in chemical engineering from MIT. She then attended the Tufts Medical School Medical Scientist Training Program, where she received her MD and PhD. Dr. Sachs completed her residency in internal medicine at Caritas St. Elizabeth Medical Center and went on to complete her fellowship in hematology, oncology, and transplantation at the University of Minnesota. In 2012, she joined the faculty as a physician scientist at the University of Minnesota. Dr. Sachs leads a basic and translational research lab focused on identifying the molecular mechanisms of self-renewal in acute myelogenous leukemia. As a hematologist and oncologist, Dr. Sachs specializes in the care of patients with blood cancers. Following Dr. Sachs' presentation, we'll hear about the remarkable journey of leukemia survivor and advocate Kevin Jansen. I will introduce Kevin a little later on in our program today. Before we dive in, I'd like to cover just a few housekeeping items. First, today's Fireside Chat will be recorded as we always record them, and it will be available on the Masonic Cancer Center's YouTube page. For University of Minnesota employees and spouses participating in the university's employee well-being program, you can earn your well-being points for attending today's Fireside Chat by completing the form that will be in the chat shortly. I'd also like to encourage our audience to get familiar with using the Q&A feature, which can be found at the bottom center of your Zoom screen. Throughout the session today and presentations, please use the Q&A feature to submit your questions, any comments you have, and reactions as well. We have time set aside at the end for a Q&A with our speakers. And without further ado, I will now hand things over to Taylor. Taylor, the virtual floor is all yours.
Wonderful. Thank you, Amna. I'm gonna go ahead and get my screen. So as Amna mentioned, my name is Taylor Kadlac. I'm the Patient and Community Outreach Manager for the Upper Plains region at the Leukemia and Lymphoma Society. And what that means is I have a 4-state region here in the Midwest where I make sure that patients, caregivers, healthcare providers, anyone affected by blood cancer in my area know about the resources that we have available here at LLS. And I'm going to go through some of them real quick for you right now. So our mission here at LLS is to cure leukemia, lymphoma, Hodgkin's disease, and myeloma, and improve the quality of life of patients and their families. And we move this mission forward through three pillars. Our research pillar, we fund millions of dollars into research for new therapies and long-term survivorship resources for families, policy and advocacy. They do really cool things over on our advocacy team. Right now, there's a huge focus on the financial toxicity of going through cancer treatment and policy reform to help ease some of that. And then our third pillar, education and support, is where my role falls under. So we're going to focus on that today here a little more. And if you know nothing about the Leukemia and Lymphoma Society and what we have available, a really great place for you to start is our Information Resource Center. So this is a call center that's staffed by master's level and higher social workers, specializing in oncology, nurses, health educators, who are really there to have a personalized, individualized conversation with you about your situation and what would be helpful for you. And from there, they can send you to other areas of the organization to receive that support. We speak your language. We always have a Spanish-speaking information specialist on staff, and then have the ability to translate into over 350 other languages. So a really great place to start if you're unsure and just want to know what is available to you. Many patients come to us first because of our financial support program. So we do have financial aid available to blood cancer patients. One of the top patient aid program is one time for anybody with the blood cancer diagnosis, can $100 financial assistance that can go towards anything. Doesn't need to be a medical expense. So really 100% of blood cancer patients in our area can receive $100 from Leukemia and Lymphoma Society. Then we have a couple travel assistance programs, depending on what type of treatment you are planning to receive. Our urgent need program, you can apply for annually for a $500 stipend. And then our copay assistance program, this is the only one that patients are required to have insurance for because it is a copay assistance. And that funding depends on your diagnosis. And I believe it goes up to about $10,000 a year, depending on diagnosis, to help ease those financial costs, whether it be copays, premiums, labs, medications, what have you, to help with those payments. And then we have a ton of education and support. I'm going to hit on all these super quickly. Nutrition consultations are really popular. This is a 30-minute phone call with a registered dietitian about healthy eating with the cancer diagnosis. It can be for a patient or for a caregiver to learn about how best to combat maybe symptoms or how to eat healthier with a new diagnosis or anything along those lines. We have educational webcasts available if you want to watch information on new therapies or anything coming down the pipeline. The Bloodline is our podcast. All of these have specific episodes for patients as well as for caregivers. So there is something for everyone. LLS community is like a social media for the blood cancer community to go online. We have weekly online chats, which are like support groups. There's in-person support groups, one-on-one connection, first connection program if you want to talk to somebody who was in a similar situation to what you're in now. Maybe you're getting ready to start a new drug and you have questions and anxieties around it and you want to talk to somebody who went through it and is now on the other end. We can pair you up with someone like that just to make that connection and ask some questions to someone who you can relate with. And then a ton of print materials available that you were able to order online. All of this is free of charge. I can order it for you, or it's all available online if you don't want a physical copy. And then the last thing I'm gonna touch on today is our blood cancer conference. We're super fortunate to have our blood cancer conference here in our backyard in St. Paul. So the Upper Midwest is on October 19th in St. Paul. And this is a really good day to meet other people who are going through something similar. There'll be speakers, experts in the area of blood cancer, research, treatment, survivorship. They'll be presenting information on various topics, and then you can sign up for the topics that resonate with you. The goal of the day being to educate participants about treatment options, emergent therapies, and management of survivorship issues, and of course, LLS resources. The conference is free of charge, lunch is provided, parking will be covered, and we'd love to see everybody there since it's so close by. I want to be respectful of time and make sure Dr. Sachs has what she needs has the time she needs to present on the important information she has today. So at this time, I'm going to hand it over to you, Dr. Sachs. Thank you.
Hi, welcome everyone. I'm going to share my screen. Let's see. Okay, so I'm assuming this is good and I'll let you speak up. Somebody speak up if you're not seeing the presenter.
You're good to go.
Excuse me?
You're all good to go.
Great. Okay, great. Well, thank you so much for having me. This is really fun for me to be able to talk to you all about blood cancers. So just as I think Amna mentioned, I'm a physician here at the Masonic Cancer Center, and I take care of patients with blood cancers. And, you know, a lot of people really, the first thing they really want to know is how do I know if I have a blood cancer? How can I tell? And blood cancer symptoms are really vague, I would say. You know, we'll go through some of these and we'll go through why people feel these things, but the takeaway point is really there's no specific symptom that makes me think, if somebody tells me on the street, oh, I have these things, there's no specific thing that makes me think, oh, wow, that sounds like a blood cancer. They're vague symptoms that, and all of us will experience most of these at some point in our lives. But let's think about what blood cancers do, right, is they form tumors. And so tumors might press on some normal organ, or blood cancers can infiltrate a normal organ, right? So that can damage the organ. So blood cancers can cause damage to normal tissue or pain because of where they're pressing. And the other thing that blood cancers do is interfere with normal blood cell production. And we'll talk a little bit more about what the blood is supposed to do, but at this point, we can just say that when you interfere with normal blood cell production, it leads to immune suppression, which can cause infections. It leads to a lack of red blood cells, which some of you may know as anemia, right? And the problem with that is that you're not delivering enough oxygen to the tissues. And then the other part of blood is platelets, and platelets are important for clotting. So if you're missing the clotting factor, the clotting cells, people end up with bruising or bleeding. And so all these things together can cause fever, fatigue, or you might feel hot, or you might feel cold, or headache, weight loss, bleeding, in the gums or other places, rashes, pain. And as you know, we talked about bruising and loss of appetite. I mean, this is not really, having all these things doesn't mean you have a blood cancer, So let's talk a little bit about blood. What is blood, right? So blood is the liquid stuff that flows through our veins and arteries. And it's composed of three kinds of cells. So there are white blood cells, and white blood cells refers to your immune system. Your entire immune system is composed of white blood cells. It's made up of white blood cells. And there are many different kinds of white blood cells, but for now, we'll just call them white blood cells. And now those are depicted here in this cartoon and here in this cartoon. There are also red blood cells, and those are the little ones, the disc-shaped ones. And there are many of them in this liquid blood that we have. And that's how we get oxygen, the oxygen from the air we breathe, delivered to our brain and our kidneys and all of our organs. And then platelets are these tiny cells, and they form clots. So if you cut yourself or you bump into something and you break open blood vessels, the platelets will clump up and prevent you from bleeding. So that's the job of blood. Okay, and blood is made in the bone marrow. So not, in the bone, the outer part of the bones provides support for our body, and inside the bone, there's the bone marrow. In addition to blood, we have organs that support the work of blood. So one organ is the thymus, and this is a really specialized organ that allows a certain kind of immune cell called a T cell to develop fully. So that's what the thymus does. It's just like a school for T cells. The spleen sits on your left side, sort of right next to your stomach. And the spleen is an organ that has a lot of different functions, but it basically helps blood cells do their work. And in addition, you have these lymph nodes, and lymph nodes are all over the body. They're associated with your lymphatic system. And this is a way for immune cells to go and sit in these little nodules all over your body. And the immune cells sit there and they survey and they monitor the circulating blood. When they see something funny, something that shouldn't be there, like let's say a cell that's infected with a bacteria or a virus, the immune cells are then exposed to that infected cell and can attack it and kill it. So that the lymph nodes are an important way to survey your blood for infections. So what are blood cancers? Blood cancers, I'm going to divide them into 3 general categories. So one of them is leukemia. Leukemia originates in the bone marrow. So here we're looking at a microscopic view of the bone marrow where we see all those white circles are just fat, and the bone marrow is supposed to have a lot of fat in it. This is appropriate. And then these pink things are little bone islands. And the dark stuff here, that's your actual bone marrow. And that's where leukemia originates. But leukemia can also circulate in the blood. So here we see red blood cells and normal white blood cells as these lighter cells. When we have leukemia in the blood, we see more of these, what we call white blood cells, even though they appear purple here. And leukemia can be acute versus chronic. And that actually refers to the maturity level of the white blood cells that make up the leukemia. And it can be lymphoid versus myeloid. And lymphoid and myeloid are different components of the immune system. And they have very, very different jobs in the immune system, the lymphoid and myeloid cells. And when it comes to causing leukemia, myeloid and lymphoid leukemias behave very differently and they're treated very differently. So that's why we make an important distinction, because it's a really important distinction in how we treat them. So lymphoma is a disease that can kind of originate in multiple places. It can originate in the bone marrow, but as the name would suggest, it often originates in the lymph nodes. So these nodules that we talked about that exist for helping your immune system clear your body of infection, these nodules, the immune cells can form tumors in these nodules, and you might have a single nodule that's a lymphoma. You can have a group of them all together in one spot, or they can be all over the body, or they can be all over the body and in the bone marrow. And lymphoma can also infiltrate organs. You can find it in the liquid around your lungs or in the gut. So it can be really in many, many different places. As the other part of it is lymphoma is a lymphoid cancer, not myeloid. And then multiple myeloma is another special kind of cancer. It behaves a little bit differently than other blood cancers. Again, this is a lymphoid cancer, but this is a cancer that tends to form tumors in the bone. So it can originate in the bone marrow, but it can also cause tumors in the bone. And what we're looking at here is an X-ray of a bone, and you see these holes in the bone because the tumors from the multiple myeloma burrow in the bone and cause these lesions in the bone. And the multiple myeloma cancer produces antibody. So unlike the good kind of antibody that your cells normally make for the purposes of fighting infection, the multiple myeloma antibody is usually not a functional one. So it doesn't actually help you. It's just mucking up things. And a big place where it mucks up is the kidney. So the multiple myeloma can infiltrate the kidney and cause kidney damage. And these are sort of the classic problems with multiple myeloma, in addition to the kind of common issue with blood cancers that multiple myeloma can also inhibit blood production. Okay, so this is a question I get a lot that people want to know. What are the risk factors for blood cancers? And the fact is that most patients with blood cancers don't have any risk factors. There's nothing they did. They ate right, they exercised, they did all the things you're supposed to do, but they just got unlucky. And that's mostly the case. But there are some things that do increase your risk of blood cancers. There are genetic syndromes, meaning, something you inherited in your family. Our cancer patients are patients who got chemotherapy or radiation for some other cancer. Rarely, but it happens that they get a blood cancer just as a consequence of exposure to chemotherapy and radiation. So this isn't a common one, but it really happens. Smoking also increases your risk of blood cancers. And then environmental toxins like, some of the solvents used in factories and things can increase your risk of blood cancer. So screening, do we screen? So by screening, we think of a person who's healthy and doesn't have any disease, and we are looking for disease in that person. The best way to screen is probably a complete blood count, just a blood test. But if we are worried about a blood cancer, oftentimes the blood is not enough. Oftentimes the blood actually looks normal. And here's a normal bone marrow, for example. So we need to do a biopsy. So we either would need to biopsy a tumor or a bone marrow biopsy. And here we've got a normal looking bone marrow, normal looking blood. In acute leukemia, for example, the bone marrow will be replaced with these leukemia cells. This is what a leukemia cell looks like under the microscope, and we may or may not see those leukemia cells in the blood as well. Okay, so this is a little more complicated, so bear with me, but cancer in general and blood cancer specifically are caused by changes in your genes. So those are usually called mutations. When your big molecule of DNA is broken and put back together, those are called chromosomal abnormalities, so that the whole chromosome molecule. And those genes, those mutations and alterations are really, really, really important to us because we've learned that those molecular changes help us to understand the subtype of the blood cancer. They predict response to therapy. And in many, many cases nowadays, they can tell us about a drug. We have a drug that treats a very specific molecular abnormality, a specific gene change. So this becomes something that we are very, very interested in because it helps us to treat our patients properly. So that brings us to treatment. There are three big classes of treatment for blood cancers. We have chemotherapy and radiation therapy, targeted therapy, and immune therapy. And we'll kind of talk about each of those. So chemotherapy and radiation is the oldest form of cancer therapy, and it's been used for many, many, many decades. And in blood cancers, these forms of therapy can cure a lot of our patients. A lot of our patients just get this old-fashioned therapy and they're cured. The cancer goes away, we don't see it again. So we like to use this stuff, Chemotherapy and radiation therapy works by killing off rapidly dividing cells. So you can imagine that while cancer cells are rapidly dividing, you have a lot of other cells in your body that are rapidly dividing, most notably the lining to your stomach and intestine, your mouth, the cells that grow hair. So that means that the side effects of chemotherapy are what happens when you damage those cells. So we see a lot of loss of appetite, mouth pain, nausea, people get tired, people lose their hair. And here what I have is just a single page from the side effect list of one of these chemotherapy drugs. So the list is a very, very long list of side effects, as I think everybody's aware. And here are some examples of very effective and traditional chemotherapy drugs that are usually infused to our cancer patients. So the next type of a class of therapy is targeted therapy. And when we talk about targeted therapy, what we are talking about is basically the fruits of labor from the molecular revolution in biology, meaning, the last 3-4 decades or so, when people study biology, they're studying it at the molecular level. We identify, here's our DNA, and we identify something broken in the DNA. And this, alteration, this mutation in the DNA leads to a protein that's behaving badly in some way. And what scientists have done is recognize the way in which this protein is behaving badly. And they've actually designed molecules that can go in and stop it from behaving badly or stop it from doing what it's doing. And so this is one form of targeted therapy. It's a therapy that interferes with that damaged cancer molecule, which to me really, as a biologist, as a molecular biologist, is super exciting that we can do this. Another class of targeted therapies are therapies where we've recognized that cancer cells actually put these abnormal proteins on their cell surface. Cancer cells can't help it, but they identify themselves with these labels. And so we can take a molecule that recognizes these labels and make sure that any cell that has that label on it is killed. So that's when we attach a specific molecule. We attach a drug on a specific molecule on a cancer cell, and that targets that cancer cell for destruction. And this works. There are a lot of drugs that work through one of these mechanisms. Our favorite, of course, is imatinib, which was the first FDA-approved, molecularly designed drug in blood cancers, and significantly improved the lives of patients with chronic myelogenous leukemia. So then we come to the last class of cancer therapies that I think is the most exciting in modern times, is immune therapy. And immune therapy itself is divided into a lot of different categories. And this has really, really revolutionized. It's the latest wave in revolutionizing the way we treat our cancer patients, and also how blood cancer patients are living such better lives now because of immune therapy. So there are a bunch of classes of that, and I'm just going to go through each one to talk about what each one is. So the first and oldest is hematopoietic stem cell therapy, transplant, which is also known as bone marrow transplant, or BMT. So I think a lot of you will recognize the term BMT. So a bone marrow transplant refers to where we get the tissue, which is the bone marrow. But the tissue that we're actually interested in is those early cells that give rise to blood. So the cells that make normal blood are called stem cells, blood stem cells. And in medicine, we call blood as hematopoietic. So it's a hematopoietic stem cell or a blood stem cell transplant. And we used to always get it from the bone marrow. Now we've learned how to make those stem cells come out of the bone marrow, and we can just get it out of the blood. So we call it hematopoietic stem cell transplant because we don't always go into the bone marrow to get it. These are all details. The bottom line is this is the oldest form of immune therapy, and this is one of the forms that we like a lot here at the University of Minnesota. We're one of the very first centers in the world to perform a successful bone marrow transplant. So we have a huge, rich history in using this kind of therapy. And you might have heard of an autologous stem cell transplant or an allogeneic. So in an autologous stem cell transplant, we are using a patient's own bone marrow and just giving it back to the patient. And the reason to do this is that we want to give the patient a really high dose of therapy so we can kill off all the cancer. But if you do that, you cause toxicity in the bone marrow. So that's why we take out some bone marrow, give the therapy, and put that healthy bone marrow back. So this is really not a form of immune therapy, we don't think. This is just a rescue method to allow a patient to get a very high doses of chemotherapy. In contrast, the allogeneic stem cell transplant is using a donor bone marrow into the patient recipient. And we're really counting on that donor immune system to recognize the patient's cancer as foreign and to kill it. So this is an immune therapy. The next form of immune therapy is using antibodies. So antibodies are proteins that your body naturally makes that recognize foreign things and label foreign things for destruction. Okay, so antibodies are the body is very, very well designed to generate antibodies that are very specific for different proteins. And so we have figured out how to make antibodies that are very specific to those abnormal molecules on the surface of a cancer cell. And so if you just treat a cancer cell with an antibody that's specific for it, the body knows that any cell that's like labeled with antibodies needs to go. So the body will naturally take care of this. And the most common and probably well-known form of this is Rituxan. That's how rituximab works. It's just an antibody that recognizes these proteins on a cancer cell. Another way that this is done is to attach a toxin onto the antibody. And so the antibody now becomes a guided missile. It just brings a toxin to the cancer cell, and then this toxin kills that cancer cell. So that's an antibody drug conjugate. And so these are ways antibodies are used, and these are considered immune therapies. The other one that's very famous, in cancer in general, and actually has less use in blood cancers, is what we call checkpoint inhibitors. So this is a little bit more of a complicated story, but also I think a really interesting one where we figured out that cancer cells have figured out how to prevent the immune system from killing it. So a T cell is an important immune cell that's looking for abnormal cells, and it will kill off abnormal cells. But the cancer cell has figured out how to tell the T cell, nothing's wrong here, leave me alone. The checkpoint can be blocked. It's a T cell checkpoint. And so now we have drugs that interfere with that message. They interfere with the message of the cancer cell telling the T cell to leave it alone. And when you interfere with that, the T cell now says, oh, wait a minute, I know I'm supposed to get rid of this cancer cell. And the T cell works. So this is a really exciting way of treating cancer, and it really works well in a lot of some specific cancers. Now back to antibodies. So this is a cross between antibody and T cell use, because here we have an antibody in a bispecific T cell engagers. We have an antibody that recognizes the cancer cell, and it's attached to another antibody that drags over a T cell. So this molecule, all it does is brings together a cancer cell and a T cell. And when you bring the T cell close enough to the cancer cell, the T cell knows what to do. It gets rid of it. So this is another way that we treat some blood cancers. And then, of course, the one that people are most excited about is what's called chimeric antigen receptor T cell. So that's the CAR T cells you might have heard about. So we're back to our T cell, right? So the T cell's normal function is to kill bad cells. But now, cancer developed because the T cells didn't get rid of that cancer. And so we take a patient's T cells, and we genetically modify it so it does recognize the cancer cell. We force it to with genetic modification, and that genetic modification generates a protein that's called a chimeric antigen receptor, and so we call it a CAR. That's what the CAR is. So this CAR basically reminds the T cell, you need to kill this cell, and this is another really effective way that we treat cancer. And I think this is probably the most kind of science fiction-y way, but this is going on, and it's helping a lot of patients. So we've just covered these enormous advances that science has given us, and all these great treatments that we've given us, and they really work well for the patient who can receive all of these. But as you can imagine, this requires really a lot of resources, and whenever you need so much resources, it opens us up to huge disparities. And I feel like the field of disparities deserves its own discussion and its own experts. And I'm not an expert, but these are the things I've observed that, just to get your, like anything, if you diagnose a blood cancer early, your outcomes will be better. And so to have good outcomes, you need access to primary care, and you need to trust your healthcare system and your providers. If somebody comes in with a new acute myeloid leukemia, they come in, they're like, oh, I have a fever, I'm bleeding, whatever. And all of a sudden we're like, oh my gosh, you need to go to the hospital right now. We're going to admit you for a month. We're going to give you really toxic chemotherapy. You're going to lose your hair. You're going to vomit. You're going to feel awful, and you'll be out of work for 6 months. You need a lot of trust in the healthcare system to submit to all of that. The treatments are expensive, they're time consuming and debilitating. So you need a lot of supports to get through all this, not just insurance, but you need to be able to take time off work. You need somebody to take care of your kids. You need somebody to help you when you're home. This requires a lot of support. Another problem is that the best therapy is often through a clinical trial. And clinical trials in our history have been exploitive. We have enrolled patients in an exploitive way, and so there's a lot of people who don't trust us to do the best for the patient through clinical trials. But unfortunately, I mean, not unfortunately, fortunately, these days, the best treatment is through a clinical trial. And so that can generate some disparities. But of course, all of the tests and treatments that we have were developed through clinical trials. So if a clinical trial is systematically eliminating some populations, some subpopulations from enrollment, that means that the tests and the treatments that we developed are not designed for the people that we have omitted. So these are some of the big issues with disparities. And I just want to close with all the things that we're doing here at the Masonic Cancer Center. The Masonic Cancer Center, in addition to being a clinic, is a major research institution. And here's a picture from one of our recent research days. We're working really hard to define new drug treatment targets in these treatment-resistant cancers, and that's what my research is on. We're harnessing the immune system in new ways, even better ways to kill cancer. And we're doing, the University of Minnesota is really well known for our very advanced genetic engineering methods. So we're using that to improve immune therapies. And there's a huge part of the Cancer Center that's devoted really to innovative community outreach programs to try to help some of those issues I discussed with disparity. And I'll stop now and unshare my screen.
Thank you so much, Dr. Sachs, for providing just such a thorough overview of blood cancers, the therapies available, and also for highlighting the disparities and the ongoing research that's happening at the Masonic Cancer Center. And a special thank you also to Taylor for sharing all of the incredible resources that LLS has. So next we'll be hearing from Kevin. Kevin will share his cancer journey with you all today. So Kevin is a retired Twin Cities business leader whose career included raising and investing $1 billion, selling more than 25 companies owned by others, and personally acquiring, operating, and ultimately selling 3 additional businesses. Kevin was diagnosed with acute myeloid leukemia in 2001, and in 2023, he wrote and published his story of how that diagnosis impacted both his career and his personal life. He currently serves as a member of the Community Impact Board of the Masonic Cancer Center, is an active volunteer and prior regional board member for the Leukemia and Lymphoma Society. He's also a current member of the Community Advocates Program at the Minnesota Cancer Clinical Trials Network at the Masonic Cancer Center. Kevin lives in St. Paul with his wife. They have 5 adult children who have all graduated from college and left home. Kevin and his wife enjoy spending time traveling, hiking, and staying active. And I am so honored and delighted to introduce Kevin to you all today. So Kevin, the virtual floor is all yours, and please tell us a little bit more about your cancer journey.
Sure. Thanks, Amna, and good background, Dr. Sachs. You'll hear many of what I went through already summarized in the previous slides, but I can tell you they're real, they happen, that's what happens. As Amna pointed out, I live in the Twin Cities in St. Paul. One of the benefits of living in St. Paul or living in the Twin Cities is you're close to very good health care for something like this. Particularly at the University of Minnesota, I was initially treated out at Abbott. And so having both of those here in the Twin Cities, you're just lucky to be close to that if you happen to live in the Twin Cities. I'm a long-term survivor of AML. As was mentioned, I was diagnosed in 2021. At the time, I was 36 years old. So today, if you can do the math, I'm 59. At that time, I was married. I had 3 kids, ages 2, 4, and 6 years old. I had a pretty high pressure job, and my wife was staying at home given how much time and effort is taken to take care of 3 young kids. And so I was the major breadwinner for the family when this happened to me. And generally speaking, I would say I have been very lucky for my experience having cancer. It taught me a bunch of things about life in general that I still value very much today, however hard it was. once you're on the other side, it's like, wow, I learned a lot during that if you keep your eyes and ears open. And so I would say I was one of those people that had my eyes and ears open all the time. And I would also say while I had complications during treatment, they were generally manageable. And my long-term emotional and physical challenge have been meaningful. I have overcome those too. And so, it's daunting at times, but at the same time, you can get through it. And so maybe I should just start with what my treatment path looks like, and there's very likely some differences today in what would, the specific path be, given that it's been 20 plus years, but, and the U of M and LLS are doing a lot of work to improve that treatment path. So 20 years is going to make a big difference. And you'll see even in my treatment path, there was some changes made when I began the journey and then 2 years later. So upon diagnosis, which I found out on a Friday, and I actually felt pretty good on Friday. In other words, it wasn't like I thought, geez, I'm really sick. I thought something doesn't feel right. I had some blood work done earlier in that work on Friday, in that week. And on Friday, I had a bone marrow biopsy done. And that's when I received the news right after that bone marrow biopsy. And to give you a sense for how fast it could move, I found that out on Friday. Monday, my wife and I went into the clinic to kind of learn, well, where do we go from here? And by that Thursday, I was checked into the hospital to get my first round of chemotherapy. And so things move very fast. You need to move very fast depending on what type of leukemia you have. And in my case, mine was very aggressive. Acute leukemia can be very aggressive. And so my oncologist at the time, when we talked to him on Monday, I had lost my dad 3 years earlier to lung cancer. So I had some idea what, chemotherapy looked like. I asked him on Monday while they were telling me how fast things would move. I said, so how fast do I have to move? When is this all going to start? And the oncologist turned to me and said, well, given that you're the only breadwinner and that you have 3 young kids, I'm going to let you wait till Thursday. If that wasn't the case, I'd have you march down the hall into the hospital today. And so very fast, kind of shocking, if you can imagine. And that treatment path consisted of 5 total rounds of chemotherapy. The first one was a high-dose chemotherapy to basically get rid of all the cancer cells they could find, all the leukemia cells they could find, and that would be deemed remission. We can't find it anywhere. And then 4 more rounds of chemotherapy after that to hopefully take care of the problem. And I was told there's about a 40% chance of survival or that would work. And those 5 rounds of chemotherapy were given over 6 weeks. In other words, you get a week that you're in the hospital, 4 or 5 weeks out of the hospital to recover from that pretty intense chemotherapy. And then you'd start that over and have a week in the hospital again, and you'd go through that 5 times. And so, in all, that took me until probably, I think it was from August till January or February to be kind of done with all those treatments, far from recovered, physically recovered, but, you're done with that regimen of chemotherapy. So that what I'll call worked pretty well, and that I was in remission from that January or February until a year and a half later when I relapsed. The leukemia came back. Tough day to find that out. Worried the whole time that it was going to come back, given my odds of survival were only 40%. But, I knew the chances weren't necessarily with me, but I was hoping. But it came back, in the following May, or a year later, May, came back, got on the path to have a bone marrow transplant done, a BMT, and in going down that path even earlier, I had found out I didn't have any bone marrow matches across the nation, the world that would match my bone marrow that I had. And so I started doing some research. Well, what are my other options? What else can I do? I explored, different clinics across the country. MD Anderson, Fred Hutchinson, which is out in Seattle. MD Anderson's down in Texas. For those that don't know, just what can I do? I'm not necessarily eligible for what would normally be next. And between the time I was originally diagnosed and at this point, 20 months later, the University of Minnesota had started exploring and starting doing some work using umbilical cord blood and stem cells that could be harvested from that blood and doing those treatments in adults as a bone marrow transplant. They had done that and had quite a bit of success with children, but with adults, they were having trouble that they just couldn't get enough stem cells out of one single umbilical cord. And by the time I got back around 20 months later, they said, we're starting to do this using 2 umbilical cord bloods and relatively matching, stem cells and characteristics of those 2 umbilical cords, not matching twins or anything, but just from 2 different babies. And I was told I was one of the first 50, roughly, adults to go try this again because they believed that it was going to work. I'm here. It worked. I'm trying to read my own notes here. So had that bone marrow transplant on August 14th. I would say it took roughly a year to get to physical recovery. It was a long path, 30 days in the hospital just to get the transplantation done, which consisted of high doses of chemotherapy, followed by high doses of radiation to kill off, your whole immune system and get as many cells of cancer as you can get out. That was probably 7 or 10 days, if I remember right. Then you have your umbilical cord stem cells injected into your body. And basically, your body has to make an entire immune system, starting with recreating your bone marrow. And once your bone marrow is recreated, grows within you, then it starts making blood again. And the 3 components of blood, as mentioned earlier, your white cells, your red cells, and your platelets. And your red cells and your platelets you can get through a blood transfusion. In other words, okay, that you don't have those, and so we'll transfuse these into you. But your white blood cells are the ones that are your immune system, that protect you from infection. So the entire time you don't have those, that's problematic. And then if you get a meaningful infection, you have nothing to fight it. And so that's, in my opinion, or from what I know, that's where most transplantations kind of start going south. They get infected with, for instance, you get infected with COVID and you have nothing to fight it. Well, you can imagine what's that going to do to you. So I'll talk a little bit about what I'll call, given that I'm a long-term survivor, what the physical and emotional issues come with going through all of that. And this is kind of what I'll call the bad news, and I'll get to the good news later. What are the benefits of making it to the other side? The physical part of this is, what I'll call, for approximately 6 months post BMT, when you're done with that procedure out of the hospital, most people develop some form of graft versus host disease, which is frankly your new bone marrow coming from, in my case, from a newborn baby, not my own, basically looks at anything coming in your body and recognize, well, here's an invader and we need to attack it. And they also attack your own parts of your body because they're an invader in your body. In other words, the new bone marrow is not yours. It's meant to fight off anything that it doesn't recognize in your body. So it turns on itself. It turns on you. And you can have all sorts of complications with graft versus host disease. It's just a mismatch. I had stomach issues. You can have nausea. You can have vomiting, trouble eating. In my case, anything spicy, including eating pizza, which was my favorite food, I'd throw it up, and that was going on for 6 or 8 months. It wasn't like, okay, it happened when I was in the hospital. I just couldn't eat spicy food. It would just, go crazy on my stomach. And that first reared its head, graft versus host disease, about 45 days past my transplant. And the result of that is it got a little bit out of control, and I had to go back into the hospital for another week to get some high-dose steroids to get it back under control. Say the least, that was a little bit disappointing to get out of the hospital after 30 days and then a week or two later have to go back in. But that's kind of the rules of the game. That's what you're dealing with. Those are the uncertainties you're dealing with. So even today, 23 years later, I still have some minor signs of graft versus host disease. For instance, kind of allergy season right now, and I got some little weird dry stuff between my fingers. And I know it's graft versus host. I mean, it's not, that's not a normal situation to have some dry skin between your fingers. And so is that a big deal? No, but I know what it is. I guess it's a good reminder of what happened. So I would say and other things that also came with all of the treatment. So within 4 years of my bone marrow transplant, I developed a vascular necrosis, which is a problem with your blood supply to your bones, and it typically attacks your joints. And that attacked both of my hip joints, which is pretty common. And so I had one of my hip replaced, I think 2 or 3 years after my bone marrow transplant, and a year later I had my other hip replaced. And I'm 40, early 40s and getting both hips replaced. Well, you live through it. It's part of the deal. And that doesn't, things like that kind of don't go away. In fact, I just had my right knee replaced last April, and that was due to vascular necrosis that probably came from transplantation and treatment 20 some years ago. And so those are mostly the highlights. Most of what I'll call the physical problems, which for some people are severe, and those physical problems can actually kill them. The graft versus host disease, it can become a major problem. It's just rejection. And as I said, that can be a real problem. In my case, it was manageable and still there a little bit, but very manageable. I would talk a little bit more also about what I'll call the emotional effects that are long-term from going through all this. So I have developed and have had from the beginning, very shortly after going through some of this post-traumatic stress disorder. And that's just an emotional issue. Like, you went off to war, you were afraid every day you're going to die. And so when you get done with it, I have issues with some, what I'll call, depends on the time of year. In August is horrible for me. A lot of things happened in August. Both of my hips were replaced in August. I was diagnosed in August. I was transplanted in August. And so August reminders come up like, wow, this happened in August. And what does that post-traumatic stress look like for me? I get agitated. Just, I feel like I'm in an earthquake and I just want to grab the doors and be in stability. And it's not debilitating, but it's there. And in the first 5 years post all of this, it was pretty meaningful. I'd find myself trying to go back to work and doing just fine. I could work full time, but something would come on, and for 2 or 3 hours, I'd be staring at my computer screen and having a real hard time concentrating and getting something done. I could get it done, but what might take me 15 minutes might take me an hour and 15 minutes because I was just fuzzy head about what was going on. And so it's unusual. Is it overcomable? Well, obviously, I got here today. I've had a very successful career since then. So yeah, you can work your way through it. The last 15 years, I'd say that post-traumatic stress is much better, but it's still there. I feel it every August. I try not to make what I'll call complicated decisions and rush to judgment in something in August because, this is just the wrong time to be thinking about that. And so I let it pass, or maybe I let the day pass or the week pass, or all of a sudden I'll wake up and think, God, I'm just having a horrible day. I just feel so crabby and agitated. Oh my God, imagine that. It's August 14th. I was transplanted on this day. So I'll move on to what I'll call the benefits, which I'll end with the benefits because that's the good news to hear about. I survived. That's the most important thing ever. I survived. I got to see my 3 kids grow up. What's that worth? I would say the pain and suffering was all worth it. You know, I was in a really bad place in my life when I was diagnosed. I'm in an amazing place in my life today. And if I wouldn't have the chance to fix those things that were wrong way back then, I wouldn't have gotten to where I am today. So I was given an opportunity. In overcoming it all, there's an immense sense of pride and accomplishment that washed over me. I got here. To give you a sense for how hard it was at times. So when I was in the middle of things in post-treatment, and even during, you know, when I'm in remission, which had happened a couple different times, but then was in remission for quite some time, and hopefully all the way to the cure, which I got to. My measurement of how hard it was if I got up in the middle of the night to go to the bathroom, by the time I got out of my bed and to the bathroom, I was afraid of cancer coming back. That's the level of stress that I was living in every single day. And when I got to 3 years post-transplant, was the first time I could really breathe and say, oh God, I this is where I'm supposed to be cured, and I'm finally here. My priorities in life are crystal clear. My kids, significant other, maybe most important. Living a life of urgency. When I hear somebody say, well, someday I'll do that, it drives me crazy. It's like, why isn't it today? Why are we waiting until someday? You might not get till someday. And frankly, I can relate more easily to other people going through it. And so I can help them wherever I can, which is why I'm here today. You know, this has meaning to me. How do I help? And if this isn't apparent in what I just said, the 28th of this month, I'm walking my daughter down the aisle of her wedding. Imagine how much that means to me. Can't get there. Priceless. How do you even define that? Great gift. I guess with that, I'll end. I think you take it from here.
I don't even really know what to say after that, Kevin. Thank you so much for sharing your story with us today, for being here today. And we're just so excited for all that you have coming up. So thank you for that. So we are at time, but I want to take just maybe 1 or 2 questions that folks might have. And Dr. Sachs, Taylor, I see a few questions for both of you actually, and then Kevin, there's a question that I'd like to ask you as well. So just to get things started for a Q&A, it's not a fireside chat discussion without getting our fire started. So let me just get that up really quickly. But from the questions that have come in, Dr. Sachs, I'm going to ask you this question quickly, but is there a likelihood of being diagnosed with leukemia if a sibling has Down syndrome?
Yeah, so I think the question is, that question is really a genetic predispositions question. If Down syndrome carries with it its own risk of increased risk of leukemia, but if a sibling has leukemia, so the question is, is the sibling at a higher risk of having leukemia simply by having a sibling with Down syndrome? And that, as long as the sibling themselves doesn't have Down syndrome, then they're not, at risk of the Down syndrome related effects. But is there a genetic predisposition would depend on that family's specific, situation. So just having a sibling with Down syndrome, the answer is no, that does not increase your risk, but that's probably.
Sorry, I actually misread the question. So the daughter has Down syndrome and then brother has leukemia. So is there a higher risk for the daughter to get leukemia?
Sorry, the daughter is the one with Down syndrome?
Yep.
And the brother has leukemia?
Yep.
So
in that type of scenario, is it considered hereditary?
Yeah. So, okay. So whether it's considered hereditary, the leukemia is considered hereditary or not, depends on the other situation of the family, and that might be worth checking out. But the Down syndrome itself predisposes the child with Down syndrome to have leukemia that's not actually related to the sister's leukemia. So it's a complex situation. It's, that could be discussed with a genetic counselor, and we do have, people who could do that.
Okay. Thank you for that, Dr. Sachs.
Sure.
Taylor, quickly ask you this question because it just came in and it looks like you might have actually answered it. You answered it. Awesome. Thank you for providing that number for a nutritionist. Kevin, this question is for you. Have you, when you were experiencing some of the PTSD symptoms, did you find that the mental health professional was able to help you? And do you have any recommendations on where folks can learn more?
Early on, in other words, through my path of fear of relapse that was 3 years past BMT, and then for probably another year past that, I was seeing a counselor. And she actually made the comment, there was no real official diagnosis, but she said, you should really explore what PTSD is and understand what that looks like, and suggested a couple books I read. And there isn't a simple treatment as I understand it. It wasn't so severe that, oh, you got to try this drug or try that drug or whatever. It was just more like, just raise your awareness of what's going on. And then you may just have to figure out how to deal with it on your own and know what's coming.
I know the questions are just coming through, but we are at time, unfortunately. So I want to be respectful of everyone's time. But I think just quickly to wrap up, I'll kind of pass it over to you three. Can you just tell one key takeaway that from our conversation today that you want our audience to know? Dr. Sachs, I'll pass it over to you.
The key takeaway is really, as you can tell, blood cancers are a huge variety of diseases. And I think the key takeaway is we have a lot of treatments. We have a lot of things to make it not the horrible experience that it could be and feels like. So come to us. We'll do what we can for you.
Thank you. Taylor?
I think the key takeaway on my end would be that if you are caring for somebody with a blood cancer, have a blood cancer, and are looking for resources, the best place to start is our Information Resource Center, and they can direct you from there. No one is expected to know everything that we have available, and they can really help personalize that experience for you.
Thank you. And Kevin?
I'd say where I ended, it's urgent, act with urgency, not another day, because you might not get another day. And also, if you're the patient, how do you turn this into an opportunity, not a curse, not a death sentence? And if you can do that, how you do that will make the whole experience and put your potential, frankly, survival, I think, much higher.
Beautiful way, I think, to wrap up our session today. And so sorry, everyone, that we could not have gotten through all of the questions. There were lots that came through, but we'll wrap it up here. So thank you for your thoughtful engagement and for participating in today's Fireside Chat. And a special thank you to Dr. Sachs, Taylor, and Kevin for joining us today and helping us spread awareness about blood cancers this month. So after we wrap up the session today, Zoom will auto-populate a window for you to complete a brief survey for us. We would greatly appreciate your feedback as it helps us improve our offerings. And after submitting the survey, don't close the window, because there's a link that's embedded where you can enter a chance to win a prize pack filled with goodies from the Masonic Cancer Center as a small token of appreciation for completing the survey. And the survey link, as well as Dr. Sachs and Taylor's presentations, will be sent in our follow-up email that will go out tomorrow. And lastly, join us for our next Fireside Chat on October 16th at 1:30 for a conversation on liver cancer in honor of Liver Cancer Awareness Month. Lastly, follow the Masonic Cancer Center as well as the Leukemia and Lymphoma Society on all of our social media platforms to stay up to date on future announcements and events from our organizations. Thanks again, everyone, for joining us today. I apologize that we ran over time, but we look forward to your continued engagement. Hope you all have a wonderful rest of your day and week. Take care, everyone.